Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Brittny Murphy, a registered dental hygienist, certified orofacial myologist, and founder of Connecticut Orofacial Myology. Brittny is an educator and mentor for Dental Sleep Toolbox and Airway Health Solutions, where she educates her dental hygiene colleagues on how to become an oral myofunctional therapist. She has an amazing ability to work collaboratively with dentists, orthodontists, oral and maxillofacial surgeons, otolaryngologists, speech-language pathologists, allergists, and other healthcare professionals to get her patients the care and attention they need. She is also the host of the successful podcast, I Spy with My MyOI, which I love the name of and actually had the pleasure of recently appearing on as a guest. I'll put a link to our episode in the show notes for today's episode of the Doc Podcast in case you want to check that out. Some of what we discuss on today's show includes what actually is orofacial myofunctional therapy, how one becomes an orofacial myologist, and why Brittny developed such a passion for it. Brittny's typical diagnostic and treatment protocols, the importance of collaborative care when treating patients with orofacial myofunctional disorders, some of the things that can be done for young children to help them develop normal breathing patterns and oral motor tone, Brittny's thoughts on treatments such as tongue tie releases, munchies, and guidance appliances, what to do if you can't find a myofunctional therapist in your area, if binkies or pacifiers are okay to use on your little ones, and if so, whether there are some that are better than others, and much, much more. So without further ado, let's get to today's episode with Brittny Murphy. Enjoy the show, everybody. Welcome to the Doc Podcast, Brittny.
Thanks for having me. I'm super excited to be here today.
Yeah, I get to return the favor here. In the intro, I mentioned how I was on your podcast, I Spy with My MyOI, which love. It's really great. And I couldn't believe when I saw my episode, which I'm going to put a link to in today's show notes, that was like, what, the 100th or 101st episode? That's a lot of episodes.
Yeah, it's funny. I started the podcast literally like 2 weeks before COVID. And then once we had the shutdown, I had so many recordings on deck. Been a little bit slow to get back into it. Like I said, you're my first one back, which I was super excited about. But yeah, I've been doing it since 2020 now.
Oh, that's great. Yeah, because you're going to be in the early 90s for me. And I feel like and I'm like, wow, over 100. I mean, it takes a lot to get up to that triple digit number. It's
Definitely.
Yeah. So, well, it's great. You're getting the message out about what you do, and that's what we're going to talk more about today. So tell me a little bit more about your background. How did you get involved with becoming an orofacial myologist? What is it? Kind of talk a little bit about your journey. You can go back as far as you want to kind of how you got into the dental arena, and then how going into orofacial myology became something. And if you would, in that, maybe just talk a little bit about the difference in the terms of speech pathologist, oral myofunctional therapist, orofacial myologist, and just try to give a little bit of clarification on what all of those things mean.
Absolutely. So let's see. I got into the dental world. This is kind of bizarre, but since I was 7, I wanted to be a dental hygienist, not a dentist, specifically a registered dental hygienist. And I just loved going to the dentist. I used when the hygienist left the room, I'd play with all the instruments. And everybody's like, oh my God, you must have had the coolest hygienist in the world. And I didn't. She actually was kind of mean. But I still wanted to be one. So no, that never changed. I wanted to go to school in Boston. I wanted to be a registered dental hygienist. I went to the Forsyth program and graduated in 2011. I was practicing hygiene full-time for 5 years before I got into myofunctional therapy.
Okay.
Now, I don't have I don't have the typical story that most of us do getting into Airway. It kind of worked backwards for me. I read about myofunctional therapy in one of my RDH magazines. The article was written by my first mentor, Joy Moeller, and I had no idea what it was. And I'm like, did I like skip school this day? Like what? I don't understand. How do I not remember this? This sounds like super intriguing. I texted like some of my hygiene friends and they're like, yeah, no, we definitely didn't learn about that. So I just dug a little bit deeper and, I toyed with going back to school to get my master's, but I didn't necessarily want to spend that money at that point. And the more I dug, I was like, this sounds really interesting. Like I needed to learn more. So what I did was I reached out to local orthodontists, other general dentists, like literally anyone to see if they knew about myofunctional therapy. And I think 2 out of the like probably 50 emails I sent got back to me. One of them being an orthodontist in the town that I was living in at the time. And he was like, oh my God, I just moved up from somewhere down south. I forget where. I used to work with a myofunctional therapist down there. I'd love to get involved. I'm like, all right, well, that is good enough for me to invest this money, invest in myself and go and take this course. Especially because at that point in time, so this was 2016, most of the introductory courses were being offered internationally. And again, as a pretty new hygienist, I couldn't really afford to send myself, internationally to go take this course. But one of them popped up at NYU, and I'm in Connecticut. It's a simple train right away. I have friends in the city. I was able to stay with a girlfriend. I'm like, I feel like this is like God's way of telling me, like, you need to do this. So I did. That was in April of 2016. I opened my practice in July. Now, of course, when I was in the course and listening to everything Airway and tongue ties and breastfeeding and blah, 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 at that point in time, all these light bulbs are going off. And I'm like, okay, my nephew was just born. He's definitely tongue tied. Or I'm thinking about this patient I just had in my hygiene chair the day before. So it worked backwards for me. Like I didn't get into it specifically for somebody, but once I took the course, I'm like, man, I'm going to be able to help a lot of people. So that's how I got into it. As far as like so the terminology, so orofacial myofunctional therapy, you'll hear orofacial myology, they're interchangeable.
Okay.
Yeah, and a majority of us that are myofunctional therapists, I would say, are either registered dental hygienists or speech language pathologists. But I do know of some really great myofunctional therapists that are also PTs, OTs. Essentially, you have to have like a healthcare license in order to take one of the 28-hour introductory courses.
Okay.
But a majority of
Interesting.
us, yeah. And what I found interesting, so you also asked like the difference between a speech therapist or pathologist and a myofunctional therapist. I didn't realize until taking this course, and like I said, besides RDHs, most of the people in the class were speech therapists. They don't learn any of this stuff in their graduate program. So unless they go on, to specialize in this field, these aren't things that they're assessing for. A lot of them are like, we don't even look in the mouth. And I'm like, huh, really?
Wow.
Like, you're not looking for a tongue tie. I mean, when people think about a tongue tie, the first thing they think about is speech, right? And that is not the only thing that it impacts, but that is the first thing that typically people think of. And to know that they're not even really learning to look intraorally is crazy to me. So big difference. But there are a lot of, wonderful speech therapists that also practice myofunctional therapy. I will say, unfortunately, if it's a school-based speech therapist, more often than not, they do not have any training. There is, and you can talk to speech therapists about this. There's something with the school systems where they like don't want them doing a lot of oral motor work. They kind of almost think it's like voodoo in a way, is how I've had it explained to me.
Yep. Yeah, I think when I had Nicole Goldfarb on one time a while back, she had mentioned something that's ringing a bell with me, something about the school system and that are not simpatico.
Yeah. Unfortunately, I mean, hopefully, again, if you interview somebody in a decade from now, that will definitely not be the case, or hopefully not be the case. But for now, their hands are kind of tied. But there are still some that still seek out the education just to learn more, or that kind of makes them deep dive into opening a private practice because there's just so many children and adults that would benefit from myofunctional therapy. Your other question was, what is myofunctional therapy? So a lot of people will compare it to like physical therapy for your mouth. I don't really love to use that term just because my background's in dental hygiene. I'm not a physical therapist. So I usually say, like, think of me like a personal trainer for your mouth muscles, right? Your oral facial muscles. Regardless of who we're working with, by the time we finish our program, by the time we graduate somebody from our program, we do have main goals in mind. And that is establishing dominant nasal breathing all day and all night, having what we call a competent lip seal, so having the lips together all day and all night, having our tongue resting all the way up in the roof of the mouth, so the tip, the middle, and the back of the tongue lightly suctioned in the roof of the mouth. Again, all day and all night. And I keep saying this because sometimes people will posture correctly during the day and not at night, and think how long you're sleeping for. We're still going to see, obviously negative effects from that. We also work on, chewing and swallowing patterns. Because I am an RDH, there's only a certain part of the swallow that I can chew on, that oral preparatory phase, where like, if, again, when you had Nicole on here, she might have been able to go a little bit more in depth. So making sure, of course, that, we're staying in our lane and practicing in our scope. But really what we're doing is treating dysfunction, essentially. Anything that is going awry with the area below the eyes and above their shoulders. We're working on breathing patterns. We're even working on postural things. It's crazy. The glossopostural syndrome, I don't know if you've ever heard of that, but basically saying how your tongue is connected to the rest of your body.
Yep.
And so if we can change that function and restore that function all the way up in the top of the chain, it makes sense where we're going to see these positive outcomes through the rest of the body. So before and after pictures are just my favorite things to look at, because sometimes like little by little you don't see it, but when you take it, like I take my photos, the beginning, the middle, and the end, it's just so cool to see the changes.
Yeah, it's thank you for explaining that really well and breaking that all down. And I love hearing people's stories, as my audience knows. And I shouldn't say always, I often find, as you said, whatever people want to call it, God's intervention, higher power, there are times at which there are these signs. Here you are, you're practicing, you're thinking about this. And then all of a sudden there's a program that's a train ride away to NYU, where you can start to get this education. And I'm sure there are little things along the way, those little lights that go off and things that pop up that make you think about this. And so you were called clearly to be doing this. This is, and your passion for it is so admirable. And the time and energy you put into this is just outstanding. And you're a real advocate for this field. And I don't just mean that as in what you're doing for your patients, which is great. I mean that as well as what you're doing to help educate others, like coming on here, like your podcast, because I find a lot of the orthodontic community just honestly has very little, if any, idea about what you just said, because we don't learn it. We are not taught about myofunctional therapy in school. We are not taught about the importance of that. We fight tongue habits and tongue thrusts with appliances, right? We may have an instructor who may talk to us a little bit about trying to give some swallowing exercises or some of the basic rudimentary fundamental techniques we could use, primitive, I would call them. But we don't understand looking at the etiology and the importance to try to have an expert in that arena intervene earlier and younger. And we're going to talk about that more during today's show. The other thing I found interesting is when you talk about speech pathologists not looking in the mouth, at first, that seems shocking, but that's the exact reaction I get when parents ask me about orthodontists and why we don't understand Airway. And I'm like, we don't look at it.
Right.
So it's, and dentists in general. I mean, you ask the average dentist how much time on my show recently, Doctors Jerry Simmons and Steve Karstensen, and Jerry was talking from a physician standpoint and Steve from a dentist standpoint. And they were both saying physicians and dentists get like nothing on airway and breathing. So as much as it sounds crazy, someone could be a speech pathologist and not really look in the mouth. This is unfortunately how education goes sometimes.
Yeah. And, it was really interesting because when I came back from taking the course, I was like, I wonder if the orthodontists that I worked with as a hygienist, are they noticing or documenting these tongue thrusts and, low tongue postures? So I would go back to some of the reports from patients that I remembered were in ortho at the time and see them, notate that there's a tongue thrust going on and that can, impede with stability of results, but then no recommendation as to what to do with it.
Right.
And, some of the orthodontists, they're like, well, I don't know anybody, so I don't really know what else to do.
Yes.
And, yes, you can give some swallow exercises, but one thing that I definitely want to say is sometimes people, or they used to call myofunctional therapy tongue thrust therapy. And it is just so important to correct that, because really what we're correcting as myofunctional therapists is oral rest posture. We're restoring proper oral resting posture. When you think about the way teeth move, right, through light continuous pressure, not through these heavy intermittent forces. So it's
Mm-hmm.
not that tongue thrust, that heavy intermittent force, that's really disturbing things. It's the overall oral rest posture. If you add
Mm-hmm.
up the amount of time that you swallow in a day, it's something like, I don't know, say half hour, 29 minutes, I think it technically is, but we'll call it 30 minutes for my math brain here. What are you doing in the other 23 and a half hours of the day, right?
Mm-hmm.
That is what's going to matter. So the tongue thrust is easier to pick up on. So I think
Yep.
that's why it gets the focus. But to me, when I see a tongue thrust, that is a symptom of incorrect oral rest posture, which is really the issue.
Love it. Just like seeing dental crowding is a symptom of a transverse deficiency or arch length deficiency. It's not because of the big teeth, or in your case, the tongue thrust isn't because of the big tongue, or
Right.
you know, and again, are there outliers? Yes, there are patients with macrodontia. There are patients with macroglossia. We understood, but 99.9% of the patients that we're talking about that we're seeing this in our respective offices and clinics are not going to fall in that category. So when you talk about the oral rest posture, I want to read you the American Academy of Pediatric Dentistry, to your point, says that the resting pressure from the lips, cheeks, and tongue has the greatest impact on tooth position, as these forces are maintained most of the time. So if people hear what you just said and think, well, no, it's got to be the thrust because the tongue is such a strong muscle and it's pushing. Yes, but the tongue is a strong muscle that can also be resting. And you also hit on something that I want to touch back on with the orthodontist that sees this and recognizes this, which that is one hurdle, because when I teach residents and younger docs, I find that it's not intuitive in our thought process to start seeing that persistent open bite or lateral open bite or shallow bite that should be closing and think tongue. We think, what did we do with our orthodontic mechanics with that? So that's one hurdle. The other thing that you said, which is so true, and it's happened to me so often, is what do you do? What do you do? When I saw that, I now know of an oral myofunctional therapist in the community where I practice in upstate New York, because she and I have become friends and have talked and spoken together on how to try to help with some of these cases, trying to help her find an orthodontist up there who will understand what to do, or an ENT, which are going to come to that part in a moment. But when I was practicing, I didn't know her. I didn't know of anybody who did this. And I was on the cleft craniofacial team at the hospital at Albany Medical Center. So, yet, and the, speech was amazing on that team. We had Jackie, who was with us. She was absolutely amazing. But I never made that connection between the fact that I could do something for this patient other than try to teach them, or put like little tongue spurs behind the front teeth, which do help. I will have to say, like, some of those patients, because it'll help redirect the posture when they feel those, and you educate them when your tongue touches those, bring it back, put it on the roof of your mouth, teach them where to put their tongue. Some patients can actually learn from that. But I'm certainly not the expert in that arena. I was just trying to kind of wing it, just to do everything I could do to try to help this patient. So what do you say to those orthodontists? Because as you alluded to, there are not a lot of you out there. And especially in certain communities, there are none. So what do you say to the orthodontist or dentist or pediatric dentist who is seeing these oral habits? Let's just go with, say it's a tongue thrust for right now, right? Or let's even actually say mouth breathing, right? Snoring, chronic open mouth. You were talking about having normal rest posture all the time, nasal breathing. We detect this. What do we do?
Right. Yeah, it's hard when there's nobody, in your community. I mean, what's great is there are a bunch of directories that are being built or already existing. So I'm on faculty with Airway Health Solutions, and we do have a myofunctional therapy finder. There's a few others. You can look through the IAOM, which is the International Association of Orofacial Myology. They have a directory.
Can I put a link to I'll put a link to the AHS one too, but can I put a link to if you give me that, I'll put it with the show today. Okay, great.
Yep. There's the AOMT that has a directory. There's a few different directories out there. So you could start there. If you know of a hygienist locally to you, or a speech pathologist, get them trained, have them in your office. How great would it be to be able to offer these services in the same four walls of you treating, orthodontics or, release procedures, whatever kind of provider, that you are. Send somebody to get trained. Go with them, because I think it's also important. I love when I have like the hygienist dentist duo in my course, because it is so important that they're getting backed, that the dentist is backing up the hygienist with what's being said. And not that I think that dentists should be providing the therapy, because I think that there's a lot of other valuable things that they can be doing with their time. I think it's important that they understand dysfunction in the mouth, what that means, how it's going to present, and how it can quickly be assessed in a simple hygiene routine. So I would say look at directories, Google. I mean, literally, like just literally type in Google, find a myofunctional therapist near me. Get somebody trained, connect with even somebody in a different state. So as an RDH, I can see patients all across the United States. I actually see patients globally. So you don't have to have somebody local to you. Now, if we're like little ones, like 2, 3, 4-year-olds, really tough to, do virtually. Oftentimes we're suggesting that they see somebody in person. But other than that, 5 and above, there's no reason that we can't treat that patient virtually. So just know that you don't have to be limited to that. We are able to do all of this through, different platforms.
And what about cost? You don't have to give exact numbers, but is this something insurance typically covers? Because I found that I get asked that by a lot of colleagues is what if patients can't afford this, or how much does it cost? I guess the other part would be time. What are we looking at when we try to tell our patients, hey, I think this would be a case where we could benefit from some oral myofunctional therapy, which we'll come back to in a moment, sort of, again, what we're looking for and what can be done. But we're there. And a parent says, how much time is this going to take? How much does this usually cost? Does insurance cover it? And does it work?
Right. Yeah, those are all really great questions. So for insurance, it is not typically a covered expense. Now, the reason why is there are currently no existing myofunctional therapy codes. So I do provide super bills for my families, but the codes that are on there are technically physical therapy codes. It's neuromuscular re-education, therapeutic exercises, which is the closest thing to what it is that I'm doing. I am doing neuromuscular re-education, but as an RDH, I can't bill insurance, right? So there's that caveat. As a speech therapist, even though, and I'm not a speech therapist, so obviously don't know exactly how this works, but from what I hear from colleagues is, again, not that there's myofunctional therapy codes that they can be billing for, but oftentimes, if there is an OMD, there's usually some kind of speech thing going on. So oftentimes they can bill for a speech service, but also provide myofunctional therapy in that session. So sometimes speech therapists will be able to get coverage. But for me as an RDH, I am not able to. I will say that over the last, I don't know, maybe 2.5 years or so, I have found more families getting something. So a lot of my families will apply for like a gap exemption, meaning that there is no practicing provider, they're a physical therapist that is providing these services within like a 50-mile radius or whatever it is. And sometimes they'll get coverage that way. But we do accept like HSAs, so health savings accounts, FSAs. Most of us have different payment plans and packages. So and as far as like price, that's hard to say because geographically it's going to matter where you are. Time wise, I would say typically probably somewhere 4 months to a year. It depends. It could be longer.
And is that like with like weekly interactions or?
Yeah. So that kind of also depends too, right? Like, so my mentor taught me like every patient's a snowflake. So, I would say in the beginning, I'm either seeing my patients once a week or once every other week. I don't want more time to pass than 2 weeks before I see them. However, in some cases, like let's say a patient going through, I don't know, clear aligner therapy, and their treatment plan is 18 months or something, say. I want to see them at the end of that. So I might kind of stretch their appointments a little bit as things are, changing dentally, so that we can fine tune, tongue placement, tongue posture, making sure we're getting, the tongue fitting within the actual dental arch. So it does kind of vary, but I would say on average, yes, they're weekly to every other week. And then as you get farther along in a myofunctional therapy program, one of the biggest things, and everybody's question is like, do I have to do these exercises for the rest of my life?
Yeah, you beat me
Especially
to
when
it.
we,
Yeah.
right? Especially when we're relating it to something like personal training. We all know what
Yeah.
happens when you stop going to the gym, right? But there's a big difference because what we're doing is neuromuscular education. So essentially, you're carving new neural pathways between the brain and the muscle so that these things are lasting.
Okay.
So not something you're going to have to be doing for the rest of your life, but you do need to learn to habituate and generalize these new functions, right, that you learned. So when we get towards the end of the program and like, let's say I'm working on making sure we're swallowing correctly, right, that the tongue is going up to the incisive papilla, that back of the tongue is elevating, we're getting that nice peristaltic motion of the tongue. I want to make sure that I'm giving my patient time to actually make this their new normal, right? So I might not see them for a month. I might give them these exercises and say, okay, I'm going to see you back in a month. I want you to make sure you're trying all different kinds of foods, right? I don't want you to just be able to do a correct swallow drinking out of a cup and with the cracker I give you. I want you to be able to swallow correctly no matter however you're drinking, straw, cup, can, bottle.
Saliva, right? I mean,
Yeah,
just
saliva, that's a
right,
big
just
one.
swallowing naturally.
Absolutely. If you're eating hard food, soft food, solid liquid foods, like no matter what it is, we need to make sure that you're doing the correct thing every time. So giving them time to actually integrate these things into their new norm is important.
Okay, great. That there's a couple things I want to touch on in there that you hit on. The timing. So you were giving the example of if a patient's in, say, 18 months of aligners, and I don't want to make this a confusing question in the way I ask it. So tell me, please, if I do and it doesn't make sense and you want me to rephrase it. But kind of the two parts to that timing, one being the timing in that patient's life when this would say be ideal or maximally effective, or conversely minimally effective, as the case may be, and the timing with relative to that patient's orthodontic treatment. Can you distill that down a little bit? Like when we should be really trying to get, in other words, if we see a tongue thrust in a patient at 4, is that as big of a concern as if we see it at 8? Does it matter? Would it be better to catch it at 4 than 8? And then the other side is if that same patient is going to need some sort of arch development or expansion or whatever the case might be, can it be concurrent with what you're doing? Or do we have to try to get you a more normal framework and anatomy first?
Yes. Okay. Let me make sure I captured all of that. Okay. So first question or first answer, again, myofunctional therapy is based on principles of neuroplasticity. One of them being age matters, right? Now, I'm not saying that we can't do myofunctional therapy with an 82-year-old because I have, and I have successfully, but it's obviously going to be much easier in a 5-year-old who's still growing and developing, right? So age-wise, my train of thought is the sooner the better. The first sign of dysfunction, we need to catch it. We need to start working on it because form follows function. So if those muscles aren't functioning as they should, that's going to impact the way that our jaws grow and develop, right? So we want to, maybe they're not ready for a full-blown myofunctional therapy program, but at least getting some good habits in there and building like strong foundations for good muscle function.
Okay.
As far as the second scenario goes, so say a patient that we know is going to be going through expansion. In a perfect world, now, depending who you talk to, a myofunctional therapist might say something different, but I'm going to tell you how I practice. So if a patient's going through expansion, in a perfect world, I would love to see them pre-expansion because I want to know their baseline, do an evaluation. I'd love to see them for a reevaluation once they are expanded and then start their treatment. Now, to your point, if I'm trying to teach somebody to rest their tongue in the roof of their mouth and there's just like literally not enough real estate going on up there, it's going to make my job very difficult and it's going to make therapy very discouraging for the patient that I'm working with.
And burn them out, frustrate them. Right.
Yeah. And that's the thing, some myofunctional therapists will say, well, there's things that we can be doing in that time, like especially, if they're in a fixed expander. For me, if the palate's not free, I don't really want to be working with the patient. Again, I'm not saying those other therapists are wrong, but if you're doing that, yes, there's other things maybe you can be working on, but you're going to see that patient for many, many more sessions than you would have if you were to just optimize your time together. And that's kind of how I explain it to families. Like, I want to, especially because I don't accept insurance doesn't cover it. Like, I want to optimize our time together. I want to get those results basically as fast as we can, right?
Mm-hmm.
Um, the other problem I have with doing myofunctional therapy with a expander in is think back to what our goals are: correct tongue posture, lip
Right.
closure, nasal breathing. In order for us to be a good nasal breathing, we have to have our lips closed. We have to have our tongue resting in the roof of the mouth. And there's no way anybody's having good tongue posture with an expander placed up there.
Right.
So that's my school of thought. But again,
Yep.
there are other therapists that will do myo through that whole time. But to your point, working with kids, even an adult, they're going to burn out, right?
Yeah.
Like, there are way funner things kids can be doing than their myofunctional therapy exercises. We try to make them as fun as interactive as we can, but I can't say there's many kids at the end of their program where they're like, I want to keep doing this.
Right. Right. No, that's a great point. And it's interesting that you say about having the expander, because some of the docs and colleagues that I've trained on my approach to doing it in younger kids with just braces and wires, as we talked a little bit about, it opens up a whole nother window for getting the myofunctional therapy started sooner.
Yep.
And a lot of the colleagues that I've trained on how to expand, or have taken my online course about expanding without using expanders in these younger patients, the results they're able to get, because they aren't fighting the anatomy, are sometimes so superior. And I'm a big fan of saying, look, as long as you're recognizing the problem, getting in there early, trying to help this patient grow. If you want to use, kind of like you were saying again, with your, I'm just telling you my approach. If I get others differ, and if they want to do fixed expanders or removable expanders or what, fine. I mean, as long as we're getting in there. I've done all of those. I've done removable, I've done fixed, and for many years on thousands of patients. And I evolved into doing it with braces and wires, and did that on many thousands of patients. And I can tell you, in my hands and in the patient's mouths that I was working in, that is a way better approach to it for that main reason. And I've said this a lot of times, and I'd like to hear your thoughts. I've never seen a study on this. This is empirical, but it's thousands of cases. I would see these kids that I would put narrow arch, V-shaped arch especially, which is super common in those mouth breathing patients where it's really tapered towards the front, high vaulted palate, anterior crowding. Let's just say for the case of argument, they're 6, 7 years old. When I would put a turnkey expander in that patient, I would often end up expanding them, being really wide in the back with this like almost too wide posteriorly in the molars, especially if that patient didn't start with a crossbite. And anteriorly, or in the anterior middle thirds of the arch, they just were still somewhat deficient. It was like, I always called it a wide V. I now went from a narrow V to a wide V, and it was frustrating. And those cases still, oftentimes I'd take the expander out. They still had a high vaulted palate. And not knowing what I was doing. This is going back for the first probably 6 years of my career. So in the early 2000s, I was just expanding. I didn't know about airway. I didn't know about tongue position. I was literally just trying to stop the need to pull teeth on patients where the etiology wasn't big teeth, which is basically everybody. So almost everybody. So I saw that. And then as I went to braces and wires, and it actually started by doing it on some patients who had special needs or on the spectrum, they couldn't handle those expanders. You were not going to get them to tolerate that. And so we started trying, well, maybe some lower braces and upper, and it just evolved over the years. And actually on the homepage of my website, I've got a little few-minute video that kind of talks about that evolution for anyone who's interested. But Brittny, I saw such a change. I would see this patient back 8 weeks after putting full braces, say in a 6, 7-year-old patient, braces and wires. The first wire is an 014 nickel titanium alloy, fairly broad. It is not a strong wire. It's delivering maybe a couple hundred grams of force at most, if that. They would come back, and I have pictures showing the transverse development of these patients in that amount of time. And for years, I didn't understand what was going on. And then because that is probably less than you're getting true, real sutural skeletal change. In most studies, you got to get up to that 400. I mean, some studies show as low as 221 grams, but at 400 grams, it's sort of approaching a pound, which is like 453 grams, I believe. So when you get up to about a pound of force, that tends to be more sutural, even in those younger kids. And I'm looking going, I'm not probably, excuse me, I wasn't taking occlusal images on these patients at the time because I know the suture's already patent. There's no need. I'm not separating a suture. It's already separated. but I was seeing the change in the morphology of their palate, and it was getting broader, and the anterior middle thirds were widening out, and I swear it was the tongue doing it. Do you think, is there
No,
something?
100%.
Okay.
Yeah, I mean, and that, an orthodontist that's going to leave the palate free is like a myofunctional therapist's dream come true, because we can get in there. And that's the thing, right? Like as far as, so when a patient is going through like traditional, fixed expander, sometimes we do phase their treatment for that reason. It is nice to work on that tongue function a little bit so that we can get the benefits from having, good function to the to the muscles. But then the expander goes in and it's like, well, what's going to happen now? They can't really do what we just taught them type of thing.
Right.
So 100%. Yeah. I mean, the tongue is really that driving force. And in a perfect world, right, we're all born obligate nasal breathers. That tongue should be resting up nicely in the roof of the mouth. The pressures from the tongue, laterally and anteriorly are going to give us that nice U-shaped arch. So I 100% think that we can thank the beautiful tongue for doing that.
Yeah. It makes sense to me and made sense to me. And that's
Mm-hmm.
where I always encourage everyone I teach and train on anything. Just be a critical thinker. Look at your
Mm-hmm.
cases. Look at what you're doing at each visit. Don't just say, oh, change this wire. Look at it and be
Right.
critical, because that was how I started figuring out something different is going on here than
Mm-hmm.
what we're traditionally taught. So,
Mm-hmm.
Ansha, well, thank you for the insight on that. And yeah, to anyone now, and so the previous career I was in, and clinically, I wish I had known, because I would recognize those patients who had an oral myofunctional disorder,
Right.
and get them to coordinate with a oral myofunctional therapist to
Mm-hmm.
be able to start to work on it concurrent with my early part of my expansion. And some of those ones that were a little tougher to get the
Yep.
transverse development, or that those get that lip seal, they just, they
Yep.
tended to be more towards lip incompetent and mouth breathing. I would obviously be doing that. And on that note, with that team approach, one of the things that you excel at in what you do is working with a team.
Mm-hmm.
You have done a really good job at coordinating a team of people in this arena. So who is your team? Well, what, not specific names you don't say, but what type of what type of providers are on your team, and how do you know which patient should be going to which provider? Are you recommending that? Are you telling the dentist to do that? Like, how does that all work?
Yeah. So, I feel like, and this is like a similar role as a hygienist, and this is one of the many, many reasons I think that hygienists make wonderful myofunctional therapists, is think about like when you go for your hygiene check or your recall appointment, and you need, I don't know, some kind of work done. Let's say a crown. And the doctor comes in and explains it in this foreign lingo, and you don't know what the heck he just said.
Mm-hmm.
And then the doctor leaves the room, and the patient goes to the hygienist. What did he just say? Like, what do I have to do? I mean, I know I have to do something, but can you like explain it a little simpler for me? And we build that relationship, right? That rapport, that trust is there. Oftentimes, patients come back to a dental practice because of the hygiene team. We
Without
see
a
them
doubt.
right?
Yep, without a doubt.
So as a myofunctional therapist, it's kind of the same way. We're seeing the patients the most. So it's almost like I'm thinking back to this slide I have in one of my courses, and I have Aaron Rodgers on there in his Green Bay uniform because, again, I told you earlier, we're Green Bay fans. My husband loves Aaron Rodgers. I actually don't like Aaron Rodgers. We could talk about that another time, but I still have him in here. And it's because we're kind of like the quarterback of the team, right? So I always say, like, as soon as you spot dysfunction, send them to the myofunctional therapist, because we're very good at educating the patients, getting the family to understand what the needs are, and then helping divert them wherever they need to go first, right? Because it could be very overwhelming, because as you just said, it's a team approach. And back in the day, it wasn't, right? You went to the orthodontist, you got straight teeth, and that was it. You
Right.
didn't get sent to a myofunctional therapist, you didn't get sent to an ENT, you didn't get sent to a release provider, and it's just not a one-stop shop. But we're very good, again, at reeling it in, right? You have to be able to read your patients, and like when somebody becomes overwhelmed in front of you, they completely turn off their listening ears. So
Yes.
it doesn't matter how fancy smancy jargon you speak, it doesn't matter. They're not even understanding any of it.
Yep.
So letting them know, like, look, I'm here for you. This is what we're going to do first. I want you to go see whoever they need to see first. You know what I mean? So as far as team members, I think probably the order of it might depend on like the age of my patient, but we're always working with, and I love this verge. I don't know. Do you know Dr. Oh my God, he created Health Latch Circle. JT, Oh my gosh, James Thomas is his name. Dr.
No,
JT.
not
No,
familiar. No.
he's fabulous. You should have him on.
Okay.
But
I will make a
anyways,
note of that. Yeah.
I think I'm saying his name correctly. He has this website. It's called Health Latch Circle, and he divides everybody by the type of provider they are. So, like, I would be a functionalist, you'd be a structuralist, a release provider would be a proceduralist. And so, having each of those people, right, you have to have each one of those team members. More often than not, I'm always working with somebody like yourself. So locally to me, my structuralist, she's actually a general, who you know, Dr. Zeller.
Yep. She's actually going to be on in not too long. Yep.
Oh, good. I love
Yeah.
her.
She's awesome.
She does orthodontics. She does Airway orthodontics. So I'm very lucky and blessed to have her so local to me. Almost always I'm working with somebody like yourself, right? Because if there's soft tissue dysfunction, it's very unlikely that their jaws grew adequately, right? And again, depending on how deficient they are, they might not need to see me first. So maybe I'm saying, I want you to go see Dr. Zeller. I want you to get, a full airway evaluation and see exactly what's going on. Maybe that would then lead to her coming back, or I'm sorry, the patient coming back and telling me that she's going to go into a fixed expander. Okay, well, I'm not just going to dismiss the patient and not keep in touch with them because they're not ready for my services. I kind of still check in with them because I want them to feel safe. I want them to know they have this team of people and that we're all kind of communicating with each other. And that is like my favorite thing about the team of providers that I work with is we all will pick up a phone, call or text each other and talk about, whatever we need to. Obviously safely protecting patients' information. But anyways, so then I would check in with the patient. Let's say they're going through expansion and it's going to take 6 months or so. I would check in with the patient every 3 months and just see how everything's going. Now I know how everything's going because I'm talking to the orthodontist or the dentist, but I want the patient to know that I know everything that's going on, right? Yep. And I think that part's really important. And then as far as people always ask, where does a tongue tie come in? Like if I need to have a tongue tie release.
I was going to be asking you that. Yeah, go with it.
Again,
might as well do now.
I think there's different schools of thought for this as well. Typically, now again, as you said before, not every patient this doesn't work for every single patient, but generally speaking, I want them to be expanded first. Okay. And then we release the tie, right? Because if you release a tongue to a very narrow arch and then you expand that arch, we might have to, do a revision, right? Because we want that tongue to be able to do exactly what it's supposed to do and rest beautifully in that nice white arch that we just created. Not have this range of motion and have to squish, squish, squish in this high vaulted palate. It's just not going to work out that way. Yep. So, and again, in a perfect world, they would work with me and the structuralist together. And then we'd have the release done. They'd still be working with me. And then most likely they'd be doing phase 2 with the orthodontist or whoever they're working with.
Okay. And then how do you work? Who ENT are you kind of hoping that your dental colleagues or the structuralists at that time? That's okay. Yeah. Are they recognizing that? Are you recognizing that?
Yeah. So we definitely recognize it at my practice because not all providers are. Again, I'm very lucky to have Dr. Zeller. I know that if they see her, she's going to make the referral, but that's not always the case. Right. And I am able to recognize if somebody needs that referral. So I want to be able to have that conversation with the family so that when they do go see somebody like yourself, it's not the first time they're hearing it, right? It's sinking in more. Oh, wow. Okay. I'm understanding this. You're not the first person that told me my child needs to see an ENT. Almost always, 99% of the time, we're referring to an ENT just to get that airway clearance, right? To make sure that they're able to breathe through their nose because I could be the best myofunctional therapist that ever existed in all creation, but if they cannot breathe through their nose, I will not be able to be successful. With that being said, there are families that don't want to have tonsils and adenoids out, don't want to do anything surgically. So again, we have to meet families where they are. Okay, well, we will try some really solid hygiene, nasal hygiene regimen. Make sure that you're doing that. We'll get you in, get that expansion to try to open things that way. Unfortunately, as you know, sometimes it's unavoidable. I don't know how you feel about this, but I kind of feel like if that airway is being obstructed 85 to 90% plus, it's kind of hard to avoid surgery.
Yeah, and one thing I want to come back to, remind me if I forget, is
Yes.
allergy and the role
Oh,
potentially of
yes.
pediatric allergy. But on the structural side and the obstruction, so what my protocol typically was when I now teach it and teach the residents, when you take a cone beam, if it's 50% or less obstructive, let's say nasal passageways are clear, right? You don't have significant turbinate hypertrophy. So, and we're going to come to that in a second, but that's not a big obstacle. A pretty good patency. But when you get up to those adenoids, you've got 50% or less obstruction. Those cases, I would talk to the parents, because I had an amazing ENT who I worked with, Jason Mouzakis, up in Albany, who he's now unfortunately not practicing clinically. He's an admin in the hospital, but he taught me most of what I know about understanding the staging, the timing, the sequencing, who he was going to go in for surgery on. He was the right amount of aggressive and conservative. He knew when he had to go in. So we would look at these patients, and sometimes it would be as easy, to your point, Brittany, of having a team and communicating. I would just send him the scan or a still JPEG of that and say, hey, Jason, here's the patient's symptoms here. They are narrow, they're super crowded. And do you want me just to go in and start doing my expansion first and see how the adenoids respond? Because as the study in 2022 showed, and I saw in my patients, I show this when I present all the time. Patients that I went in, did expansion that were in that 50% range, or to your point, larger, and the parents wouldn't go to the ENT. And all of a sudden you're done with it and you take the post-treatment image and you're going, did they really not see the ENT for anything? And the dad's like, nope, we didn't want to do it, or we fell off our radar because they started breathing better. So we said, maybe we don't need to do it. So I had that happen often too. Sometimes because the ENTs there were so few that I trusted in my community, they were booked out 3-5 months.
Oh, yeah.
I'd get in there and start doing what I was doing on a patient, and the patient would start breathing better, and the parents would cancel the appointment. And sometimes they wouldn't even tell me. They'd just be like, and I would find out after the fact. So yes, that would be kind of my barometer. So if it was less than that 50, I would usually, if it was borderline, I would check with Jason. If it was less than that, I'd typically say to the parents, I'm okay with jumping in and starting to see if this helps before we go to like a surgical type option, based on, again, the severity of the sleep disordered breathing, their reports, the sleep questionnaire type questions they were answering. If they were telling me that it wasn't that severe, and I said, let's go see how they respond. Almost all those cases, I honestly don't know of one I could think of off the top of my head that didn't respond well enough that we then had to go through a surgical procedure after. When they come to me in that 75 plus range, right, I'm saying to them, not only am I sending them to the ENT, but I'm saying there's a decent chance that they're going to want to remove some lymphoid tissue here. And I was a proponent of that in the sense that we got to get this kid breathing. And if they are still obstructing so much, we know the evolution of how the parafunctional habits of mouth breathing lead to the craniofacial dystrophy and the constriction of the transverse. So it's just going to fight my expansion. It's going to fight everything I'm trying to do, especially because I did it with such light forces. If they're constricting in with that orofacial musculature, I'm in trouble. And if that tongue isn't getting up to the roof of the mouth, because they can't become obligate nasal breathers. So again, like you said, it's so hard to quantify and pinpoint an exact, sort of criteria where it's like, A, you do this, B, you do this, C, you do this. But it was a general feel that I got for it, where I would look at them and say, okay, and same thing for tonsils, if they were 3+ to 4 and, these huge kissing tonsils, and it's like, look, we got to get this kid breathing. Like, we can't be letting your child choke every night, all night long. And the tough part I find now, before we get to the allergist part, is people reach out to me all the time. Just happened last week. They can't find an ENT who will treat these younger kids. And they have a patient who has significant obstruction, and they send them to like 2-3 ENTs, and the ENTs are like, oh, let's wait it out. Let's see we'll see them maybe when they're 8-9 years old. Kids 5-6 years old, suffocating. And I just don't know. I'm not the ENT. I'm not the one to tell them, when they have to or not do surgery. At the same time, I'm thinking, I know a lot of ENTs who do go in on those patients, and the results are absolutely amazing. So not that anything you or I can solve, but just to kind of let providers out there know that's real. And that's something that is also a challenge. Yeah.
I get the same thing all the time. It's the toughest provider to have on your team. I mean, I've been doing this since 2016, and there's only one pediatric ENT that I will refer to. And I have one adult. I don't have as good of a relationship with the adult ENT, and it's crazy. And that part is hard to explain to families. Like, that not all ear, nose, and throat doctors are airway centric, because like
Right.
if you say it out loud, it just doesn't really make sense, right?
Right.
But and so that part's frustrating. And I think the other frustrating part, and I'm sure you probably get this too, is families then go and talk with their pediatricians, and oftentimes it's kind of the same thing. And they don't, and I try to explain, like, your pediatrician has to know so much about so many
Mhm.
things. Like, this part isn't really their jam, right? Like,
Yep.
you know what I mean? Like,
Yeah.
like you want to see a doctor of the mouth for that, right? You don't want to see your pediatrician.
Yep.
And I kind of will warn them a little bit, like, look, your pediatrician might disagree with me. They might not think that your child has, a restricted frenum, and that's fine. I would love to have a conversation with your pediatrician. I'd love to tell, him or her, like, what it is exactly that I'm seeing, because I want to make sure that we're all on the same page. And the other thing that I wanted to mention was, when you said about the ENTs, like, what do people do? And I'm sure you also did this in your practice, like telling families or parents to record their child suffocating when they're sleeping, right?
Yep.
Like,
Love
a
it.
provider cannot ignore that if you go to that appointment and you're showing your child gasping for air.
Right. Right. I love that. Thank you for mentioning that. I think it was one of the recent episodes I said I should mention that more on my show, because it is such a great point. So parents, I have a lot of parents that listen to this. If you have a child who is suffering from any sleep-related breathing disorder, snoring, gasping for air at night, record them, please. Video is better. But I just told a parent at the residency last week, like, I want you to record them, but you can use a baby monitor. If you have one, you can use a phone, put a phone in there, and just, put it on the other side of the room, because I'm also sensitive and I want the phone right by their head. So it's like, put it on the other side of the room, just record them and just scrub through it. You don't have to watch every second, but just kind of scrub through it fast the next day. And if they're not moving much, if they're still, if you don't hear a lot of noise coming from them, then chances are they're sleeping pretty well. Again, it's not a sleep study in that sense, but it is a really good way to determine, because if that child is tossing and turning, if that child is gasping and snoring, that is not normal, and that is not okay in a child. And anyone who tells you differently is wrong. I had Jerry Simmons on recently, who is a world-renowned sleep expert, and he said children simply should not snore. So if your child is snoring, you need to do something about it. So, and he actually went to say, and if they are, and you go to a pediatrician or a dentist who tells you, don't worry about it, find another one. And before we come back to the allergy part, I want to just highlight on something else you said, and I want to call out my orthodontic colleagues on this. And I say this all the time, I don't do this to be harsh on them. I just want them to realize that what I'm saying, Brittny just had a beautiful example of, as did that the person I referenced, who is a oral myofunctional therapist up in the area I used to practice, who is sending her patients to Massachusetts for orthodontia to a general practitioner. And you were talking about sending them to Dr. Zeller, who is a general practitioner. And so I tell my orthodontic colleagues all the time, we better get on the boat here, because this ship is sailing, and people like yourself are looking for a place to send these patients, and parents are expecting it. And all the parents say the same thing, and I'm sure they've said it to you. Why are there so few dentists doing this? Or why did I go to 3 orthodontists and none of them even mentioned Airway? I brought it up to them and they said that's not a thing. So, right. I mean, so I'd rather hear, you say it if you're comfortable. I don't want to put you on the spot on it, but I say this all the time to my orthodontic colleagues. I almost feel like it's when you tell your own children something, they don't listen. So maybe if you say it, they'll actually listen to me. I'm not saying it to be hard on them. I'm saying it because I love my profession, and I'm so passionate about this profession and what we can do. And it just saddens me beyond belief that we refuse to recognize this, and not that Dr. Zeller or this other provider aren't more than capable. And I mean more than capable, because they put the time, energy, and effort in. So I have a lot of them on my show. I want to hear the amazing things they're doing. That being said, why are the orthodontists giving up on this? Like, why are we punting? I don't know what your thoughts are on that. And have you had those frustrations yourself with orthodontists?
Oh my gosh, absolutely. Or my favorite is, like, say the parent says how my child's grinding the heck out of their teeth, and they're like, oh, well, that's common. All kids do that. It's like, again, that phrase, just because something's common doesn't mean that it's normal. Right?
Mm-hmm.
Like, there's a reason. What is the reason that these children are grinding that living daylights out of their teeth? That's not normal. Neither is it for an adult, but especially for our growing children.
Yep.
Yeah, it is very frustrating. And I think, I don't know. I mean, I always try, I get it from the other side from myofunctional therapists. Like, how do I find those orthodontists that are at least open to it? And you just, you need to talk to somebody that at least wants to listen to you, wants to sit down with you, wants to hear about your practice, what it is that you do.
Mm-hmm.
Unfortunately, at the time that we're in right now, those people that respond back or don't respond back, I wouldn't keep trying to reach out to, because there's so many providers out there. Let's get the ones first that are at least open to it, and then we could work on, the other subset. But it's incredibly frustrating. And I think, going to local study clubs in your area and asking to speak, at orthodontic study clubs or, local general dentistry study clubs, whatever it is, just trying to spread that awareness, sending episodes like this, podcasts are so great because they're conversational. So somebody doesn't feel like this information is being like shoved down their throat. It's just a very open and honest conversation.
Mm-hmm. Yeah, no, I love that. And be proactive, but also know you're not going to squeeze blood from a stone. And I've kind of taken that approach in my approach to this whole movement and everything I'm trying to do to educate and spread awareness on this. I used to put way too much energy, the fighter in me, wanted to just tell these people who didn't believe in it like this. And I've kind of realized in this state, I'm like, all they do is just, they don't want to change. They don't want to listen. So let me focus my energy on the people who do. So I love that, go seek out, try it's worth a shot, try. But if you get the door slammed in your face, you get a pretty good sense if this is somebody who's maybe open-minded and willing to talk to you about this, or somebody who's not. And if it's not, keep moving on, and hopefully someone will be open to it.
Yeah, and I always say, like, don't get discouraged, because you are making a difference every day. Everything that you're doing, trying to spread that awareness and talk to providers, you're saving a child's life somewhere. So,
and I love that, Brittny, because that is my mission. When people ask me why I'm so passionate about it, because I saw the lives I changed. I always say straightening teeth is great. And I was very blessed to have been a very good tooth mover, and am still in the educational arena, a very good tooth mover. I loved creating those amazing smiles. That being said, as great as some of those wins were, very few of them can even come close to taking a child who you catch at a young age, who can't breathe, who can't function, whose parents are sitting up at night or sleeping in the same room as every night, mom and dad taking turns sleeping in the child's room. Think of what that does to the marriage, to their relationship, their sleep, their well-being, their work productivity, to make sure their child is breathing and not choking at night. And the fact that my orthodontic colleagues, so many of them, refuse to acknowledge this and just make it about, well, we can wait, and we can straighten their teeth at 12. I like, guys, gals, like, there's so much, there's a child on the other end of this. And that is why I have made this my mission to get the education out, and love talking with people like yourself about this. So on the note of the allergist, I want to come back to that.
Oh my gosh.
Yeah. So that's something that I think we don't talk enough about as sort of all of us in this movement of awareness. I was very lucky that maybe, again, those signs from God and things that you have happen to you in your life. I'm a very big allergy sufferer. And I've had 2 sinus surgeries. I've had to go. It's probably why I have awareness of looking at CTs, and because I was looking at many of my own. I've had more head CTs than I would like to even count. But went through all of this, and it turned out it was really all allergies. The etiology was allergies, some structural stuff, but for the most part, it was allergies. So I ended up spending a lot of time in the allergist's office. Turned out my allergist became my next door neighbor at one point, and we got talking, and I just started talking to him about this. And he's like, well, just send me, if you detect some of this stuff. I was he didn't know at that point what the cone beam was. I was like, hey, I got this machine, and I was showing him images and on my phone. He's like, oh, well, if you've got this, then just send them to me, and I'll put them through my screening process, and we'll figure it out. Brittny, that was such a big part of the puzzle, because some of these kids, some had to see both allergy and ENT, but some, if they didn't have obstructive lymphoid tissue, but they had turbinate hypertrophy, obstruction in the nasal passageways, they are still not breathing through their nose because of an obstruction. And I feel like we don't work enough with our pediatric allergy colleagues to get them on board. So I'd love to hear your thoughts on that.
Totally agree with you. There's so many kids out there with unmanaged, uncontrolled allergies, or it's like this perpetual cycle that they keep chasing. It's like one of the things as myofunctional therapists that we are big believers in is routine nasal hygiene. And, I explain it like you don't stop brushing your teeth because you don't get cavities. You don't have a high caries risk. You don't have a high caries risk because you're preventatively practicing good oral hygiene, right?
Love that.
We take showers so we don't smell, right? We don't take shower. Do you know what I mean? Like we're
right. You don't take a shower just when you smell.
Hygiene,
right.
So your nose should be no different. We shouldn't just be taking care of our nose when we have a cold, when we have allergies. It's something that we should be continually doing. And I feel like oftentimes that happens. Like I'll be talking to a family and talking about nasal hygiene, and they're like, "Oh yeah, we use a nasal spray, when his allergies start flaring up. But, we haven't used it because he really was doing better, and now all of a sudden like he's not again." And I'm like, well, see, that's the thing. We can't stop, right? It takes a while to catch up, and that time we stop. It doesn't take very long for these allergies to become unmanaged again. So routine nasal hygiene every single day. I don't care who you are when I'm seeing you. If you have allergies, don't have allergies, breathe through your nose, breathe through your mouth. We want to take care of this thing, right? Our nose is a beautiful thing. We need it to be able to function and function well. So that is like a must in my myofunctional therapy program.
What are some things, I'm sorry to interrupt you, but that you would, you have to go into great detail on it, but just a couple of the things in nasal hygiene that you might recommend.
Yeah. So, I mean, a simple saline solution is fine. I like the X-Clear. So the
X-Clear is great.
the
use it
xylitol
myself.
with the saline.
Yep.
Yeah. And my husband also suffers from allergies, and the X-Clear has been a game changer for him. And they even have a fast acting one where things are really, if you're really, really stuffed up, that you can use it. It does have oregano in it, so it kind of burns a little bit, but it works really well. So, families get nervous when they hear about nose sprays because they're thinking of like steroid based nose sprays and things that of course we don't want to be on long term or chronically. But these simple saline solutions, X-Clear, can be used on an infant, right? Like I am constantly cleaning my infants' noses and making sure that they're nice and clear. And it's just something that we should learn to practice. And even as a family, like, yes, sometimes kids get a little like, I don't know that I want to stick this thing up my nose. But if they see mom and dad do it and you make it like a whole family thing, then oftentimes it's going to be, I hear often like the child is like, wait, mom, we didn't do our nasal spray tonight. You have to make it not a thing, right? That's like something that I'm learning too as a parent is just stay calm. They'll be okay. They're just a simple little squirt. You can start outside around the nostril first before they actually stick it up a little bit. You're not shoving it up to their eyeball.
And to your point, they model our behavior. If they see us brushing our teeth, then they are going to be more likely to want to grab a toothbrush and imitate us. If they see us shower, they know we get in the shower. Well, it's bath time, right? Like they understand this is, like you said, it just isn't a thing. It isn't, well, you have to do this because this is just what you do to stay healthy. Yeah.
And I think, too, we talk with families about limiting like, allergens in the house and getting rid of stuffed animals on the beds and no rugs in the bedroom and running an air filter. Unfortunately, diet, sometimes we have to talk about, dairy and gluten are big allergens. And, I usually will have my families keep like a little food journal so we can try to see what might be the culprit. But whenever you're eliminating something, you only want to do one at a time, right? Because you want to know exactly what it was that helped.
Exactly.
But unfortunately, it is sometimes having to change these kiddos' diets. But, looking at what you can get as alternatives now, kids will be fine, right? And again, if you don't make it a big thing, like they won't either.
Agreed. Yeah. I love that. Do you ever recommend an allergist and them not, kind of like we said with the ENT, do you run up against that as well, where they go, you're confident and that they see an allergist and you're pretty confident based on the parents' parents' description of the symptoms that there's something going on, and you recommend they see the allergist and they come back and say, just nothing we can really do. I mean, do you run up against that as well? Or does it seem like the allergists are a little more aware of that?
No, I mean, so far it's been good. What's great too, again, I'm lucky with the pediatric ENT that I work with. He very easily will make that like discrepancy for me if it's more him or more the allergist that the patient needs to see. So that part's really great. So I can't say that I've run into that because I feel like they're getting the care, whether they're seeing the ENT or the allergist. So you're saying some families will see the allergist and then come back and say they can't do anything for me, even though it's allergies?
Yeah, yeah, they'll just say like, "Oh, they just recommended like a saline spray," and but I think a lot of it goes down to what you're saying. They're not educating, they're not explaining. One of the reasons I loved the allergist with whom I worked was Jim Damasi's his name. I don't know. I think he's actually kind of finishing up his career, but is he took the time to explain even with me as an adult, and then with my own kids who went to him and have allergy challenges, like when he would explain to them, like draw it on the paper on the thing, like, so this is what happens. And so again, it's just, it explained to them, this is what's going on so they can understand it. And I feel like sometimes they're just looking in the nose quickly and just saying, yes, they're a little congested up there, a little inflamed, and here's, take a saline spray, but they're not going into the detail that you just went possibly with explaining why we have to do this and how we should have to do this. So
I see. Okay.
yeah. So I would, again, if parents are, if providers are out there and you sense this, and I know there's interestingly, I'd be willing to bet there are lots of people listening to this thinking, that's not our scope. Why would we be talking about the nose or no, it is anywhere, like you said, from sort of that eyes down to throat, if you want to think of it from that area as a dentist, is our scope of practice. And it's not that we are the ones who should be diagnosing them with an allergy to ragweed, but but we can
getting
clearly
them to the person that can.
Exactly. And looking toward the signs and symptoms of these allergies and the allergic rhinitis and the chronic mucus production. It doesn't take a lot more sometimes than just get to know your patient a little bit and ask the right questions on your intake forms. And you will figure out if they're a stuffy, congested, kind of always, post-nasal drippy kid. I mean, the parents are like, oh yeah, they're always, stuffy. And, so the allergic shiners on the eyes and the allergic crease in the nose and the Denny Morgan lines, there's a lot of signs that we can learn to recognize in these patients too, to say, there's a sign of atopy here. I think your child is reacting to something.
And I love what you said about, having it on your intake, and some offices, they'll always say to me, like, I don't know, like, how do we have those conversations? And I always ask, well, do you have it in your question, like your medical histories, do you have it in an intake form? And they're like, well, no. I'm like, well, that's the conversation sparker, right? Like they're filling out this paperwork. They're saying yes to all those allergy symptoms that you just said.
Right.
And so when you bring them up, it's not going to be like, well, what the heck are you talking about? Like, look right here, you said your child has X, Y, and Z. Like, you think this is normal? It's not. You know what I mean? I mean, obviously not saying it that way, but you know what I mean? Like, let that
they know
be the conversation sparker for you so that you don't have to be the first person that's necessarily saying it. They already are seeing it on this piece of paper, and you're just educating and making that connection for them.
Yeah. And people who say the pediatrician should be doing it, okay, fair, but they're not. And by and large, I mean, I'm sure there's outliers. I don't mean to make this a negative comment on the pediatrician, but I've had kids go through the system. I deal with a lot of different parents and patients I've sent and hear the feedback from their parents that it's just not on their radar. So, okay, it'd be great. Maybe we can get it there one day. But in the meantime, back to what you said, there's a child suffering here.
Right.
Let's see what we can do. So awesome. Well, want to get a couple of things here before we wrap up. And one is the question on non-nutritive sucking. And would you say non-nutritive sucking or suckling? What is the proper way to say that?
I mean, I think it's technically suckling, but I say sucking, honestly.
Okay. And is that normal at all? And if so, is there an age at which, I know the American Academy of Pediatric Dentistry says about 36 months, but what is the range that's okay? And like, is it a frequency type thing like we were talking about? Whereas if they just do it to soothe, to go to bed, no problem. But if they got this thing hanging in their mouth night and day, and then the other part is are there better or worse sort of binkies, pacifiers?
Yeah. So I think what you said about so we look at when we have patients come in with any kind of oral habit, pacifier, thumb, finger, whatever they're doing, nail biting, we're looking at the frequency, the intensity, and the duration of the habit. I think I would agree with you. I'm maybe not 36 months. I'm probably more like by age 2, we definitely want to get these things, gone. A lot of families are confused. Like they think like my child has to take a binky, and like they don't. And if they don't, that's okay. I mean, I know they say in the first 6 months of life, It does help to prevent SIDS, but children will be fine. Don't have to shove binkies in their mouth. There are definitely binkies that promote better oral function. In general, we don't really love the idea of pacifiers, but I will say, now I feel I've been waiting to become a mother to be able to have that, you know what I mean? But like,
sure.
kind of like, I want to have my tongue tie release, not because it's impacting me functionally, but I want to be able to talk to patients on a level of I went through it myself.
Mm.
So I am a new mom to 2 twin girls who were lip tied, tongue tied, cheek tied. I said at my bridal shower, my best friend got me pacifiers, and I literally remember sitting in the chair in front of everybody saying, I might as well toss these in the garbage because my babies will never use pacifiers because I know what they do to the mouth. And yes, they do damage, right? But with everything, there can be therapeutic reasons to use such things. And I learned that. So my twins were born prematurely. They were born at 34 and a half weeks. And our struggle getting out of the NICU was being able to feed orally. And it was so interesting. I remember walking into the NICU. So they were tube fed for, I think, a week and a half before they started introducing some bottles finally. And what the change was, I walked into the NICU and the nurse was sticking a pacifier in one of my daughter's mouths. And my eyes, fire could have came out of my eyes. It probably would have.
Your myo-eye.
Yes, right?
You spy with your
myo-eye. And I'm like, to my husband, I'm like, they're putting pacifiers in their mouth. And so, long story short, once she did this, it helped them coordinate their suck swallow. It was insane. Once they started introducing those pacifiers, they were able to transition to bottle feeding much better. Before, it was not working at all. Now, again, I didn't want them to get attached to them, but I was able to make that connection. I'm like, maybe these aren't bad. And then we went on to have our ties released. And I was not, unfortunately, one of those people who had their child's oral ties released. And all of a sudden, my babies were beautiful breastfeeders. It didn't happen. Took a lot of work. I saw an IBCLC. I saw an OT who specializes in feeding therapy. There was a lot of stretching orally, body that was going on. And eventually, when I worked with the feeding therapist, she talked to me about pacifiers, and she's like, look, I don't want them to have a pacifier hanging out of their mouth 24/7, but we do have pacifiers that we use therapeutically, or pacifiers, again, that are better than others. So first and foremost, the pacifiers that have the stuffed animal hanging from them, cut that stuffed animal off immediately. It's cute. They can have the stuffed animal, but not attached to the pacifier. Think about the weight.
The weight, sure.
There was that research study that came out that said, I forget exactly, well, you would probably know the weight that it takes to move a tooth, but those stuffed animals literally equate to the orthodontic force that it takes to move teeth. So,
I could certainly imagine. I mean, you get 40 grams of force, you got plenty to move a tooth, and 40 grams ain't that much. So
cut it off. Okay. Yep. Avent Soothies, I know so again, I'm not a feeding therapist, but again, colleague wise, I know things that are recommended. The Soothie pacifiers are typically recommended, but the pacifier that helped my girls so much therapeutically was the Nitty. And I would say that's probably the most widely recommended one as far as it resembling like good oral function. And it was so interesting to watch them use this Nitty pacifier. So it's clear. So you can see what is going on intraorally. And what I would do is I would have them use this pacifier for 10 minutes before I started to nurse them. And I would watch that tongue. It was doing, I'm like, oh my God, the tongue is doing literally what it needs to do. Yeah. It was the coolest thing to see. And again, I was like, no, my children will never use pacifiers for 10 minutes before every feed. We were using the Ninny. Now, my girls don't use pacifiers, not because I don't necessarily want them to, they just won't take them, which is fine. But therapeutically, we've used them for sure. And they've made a huge difference.
No, that's such a great, I appreciate you sharing that personal story as well, because that really does resonate with people to hear this. And I give you credit for being able to admit where you had to adjust a little bit. And that's why I wish more of us were that way, where we could just say, yeah, I was really dogmatic on this, but you know what? I was open-minded and I said, okay, maybe I'll try this and see what happens. I can speak to both my girls. One really did enjoy her binky, and the other could kind of care less about it. Just, they maybe soothe a little bit at bed. You go in and they'd be out of their mouth already. The one who did like it started developing, again, the things you notice when you're the parent, not just the provider, an anterior open bite. So I'm like, oh man, she's getting an anterior open bite. But again, like you said, frequency, duration, intensity.
Right.
So clearly that was excessive in her. So one
Yep.
of the ways that you can do that, and I forget who gave this idea to my wife, but the binky fairy can come, because I hear from people all the time, and and yes, there is an emotional, psychosocial impact of just ripping this thing out of this. It's their security blanket. Like, you're just going to rip it from them. So cut it a little bit each night. And it's decreasing the suction and the feedback, the neurosensory feedback that they're getting. Right. And if you do it little by little, and then usually by now they can be old enough where you can make a game and you donate it, you give it to the binky fairy, and you got to give it to other kids who can have a binky, and the binky fairy is going to come like the tooth fairy comes, and they're going to take it in the middle of the night one night because you're a big kid now. And that is definitely a way. I'm not saying that's the only way, but again, if people want to kind of wean their children off of these, a lot of times you hear like, I'm not just going to rip this thing from my child's mouth. They need it. Okay. But, and also decrease the duration, right? So that's decreasing the intensity because they can't generate as much force. Decrease the duration and the frequency. So give it to them a little less during the day, and don't let them have it. Just decrease it little by little. So some strategies there for parents. Because I used to get asked that as an orthodontist all the time. Like, they'd have a crossbite. Like, it's because they had a pacifier until they were, when they were 2, they had a pacifier. And I said, well, yeah, maybe, but usually, for us, it was like that. Like you said, that 3-4 for like the crossbite area. But I tell parents all the time, it depends, and they would kind of maintain that non-nutritive sucking pattern, but was a big problem for us, because that, and that's another thing that if you want to mention is, at what age do you think or find, or did the studies in your field show that non-nutritive sucking pattern can become persistent, and they don't develop that mature somatic swallow that they're supposed to develop, and they maintain the infantile swallow?
Yeah, I want to say it's the 36 months.
Yeah, it sounds right. I think it was like 3-4 years ago. We always learned, I think. So
I don't know for certain, but that number is resonating with me. The other thing I wanted to mention, I know we were going to talk about it, was the munchie can be a really great replacement for a binky, because to your point, they're still going to get that feedback that they're looking for, but it's a much more positive, what word am I looking for? Much more positive influence on the orofacial complex than the binky is, right? And munchies, so you can start a munchie as young as 6 months. They make a baby munchie, which is the cutest little thing you'll ever see. You can't order the baby ones yourself as a parent. You do have to work with a munchie certified practitioner, which you can find on their website. But starting on the smaller size all the way up to the adult one, anybody can go on the munchie website and order. And those are great. We usually incorporate munchies when we're doing habit elimination programs.
Okay. And yeah, thank you for going to those, because I did want to talk about that. Is the munchie concept, the sort of guidance appliances is what some call them eruption guidance appliances, some call them guidance appliances. What are your thoughts on those? Because I get told in our ortho study groups, I've heard people say when someone asks a question or they show one, like, oh, tell the parents to go to Dick's and spend $20 on a sports mouth guard. And it's the same thing. And I'm certainly not an expert in them. So I would love to hear your thoughts on what they do and if they work and what they're trying to achieve.
I think that's a great question. So when I think of myofunctional guidance appliances, I don't know specifically that I group necessarily munchie into that. I'm thinking more like MyoBrace appliances, Healthy Start, the Vivos myofunctional therapy guides. I think that as long as they are being presented for what they are, they're guidance appliances, they're not expanders, then I love them. I mean, I work with a lot of providers. I know when you interview Dr. Zeller, she'll probably talk about how she uses them in her practice. I mean, they're one tool. And I think that's the thing, right? Like, not every child is going to benefit from the same protocol, right? So if you're only doing MyoBrace in your office, or you're only doing whatever in your office, it's probably not going to work. But I do think that there's a time and a place. And I think especially for younger kids who aren't quite ready for, let's say the provider they're working with is going to do a fixed expander. Well, maybe the 3-year-old isn't behaviorally ready for that, right?
Yep.
I think that there's a time and a place. I think that I've seen them do really great things as far as I've honestly seen them fix a crossbite in how old was she? This one, I actually worked on this case with Dr. Zeller. Now, she did end up doing expansion later on down the line, but she was little when she went through her guidance appliance therapy. The thing that's great about them is they're not a replacement for myofunctional therapy, which I do definitely want to put out there, because some people think if I wear this myofunctional guidance appliance, because it has the word myofunctional in it, that is going to replace myofunctional therapy. And that's not the case, right? What is very helpful is children are wearing these myofunctional guidance appliances at night at a time where they can't be conscious or aware of what they're doing with their oral musculature, right? So during the day, they're doing their myofunctional therapy exercises, but at night, these myofunctional guidance appliances are helping to remove those unintentional pressures of the oral musculature. They're helping to promote proper oral resting posture. That tongue is going to rest up in the roof of the mouth. They have a little tab, like a little reminder for where the tongue's supposed to go. They do help to encourage nasal breathing. And work on swallowing patterns as well, because again, it's removing those unintentional pressures. So I'm in support of myofunctional guidance appliances. I know sometimes with some people they get a bad rap, but I think it really depends how they're being used. You know, to say that it's going to completely take the place of orthodontics, I don't know that I necessarily agree with that. But I think that it can really, really help set a little one up on a much better trajectory than they would have if we did nothing to intervene at that age.
Thank you. Thank you for that. That was a really great encapsulation of a very confusing topic for a lot of us in the dental arena, because we don't learn about these things. And so they do more than if you just go get
oh my God,
a sports mouth guard.
They do way more than that. Oh my gosh. Yeah, please don't just think you can do that. I don't think that is going to do anything, honestly.
Right.
So
yeah. So, well, I can't thank you enough for this. There was so much good information, and you explain it so clearly. Really, it's so great to know you now, and you've helped me connect me with some other providers, and just expanding this network, and just keep doing what you're doing. And congrats on the little ones and being a new mom. And I know that creates a whole nother set of challenges.
Oh God, yeah.
We could spend a whole nother episode on that, I'm sure, of balancing all that you do. But I really appreciate your time and expertise in coming on the show, Brittny. Thanks so much.
Thank you. Thank you for having me.
You're welcome. Last thing, anywhere that people can go to find more out about you? If I can, I'll put it in the show notes too, but.
Yeah, absolutely. I mean, if you're looking for myofunctional therapy, you can go to my website, www.ctoralfacialmyology.com. You can find me on Instagram. We have a pretty popular Instagram page, CT_oralfacial_myology. If you're a professional that is looking to learn more about myofunctional therapy, you can visit www.themyohygienist.com.
Okay. Awesome. Appreciate it. Thank you so much.
Thank you.
All right. Bye.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.